Welcome to our conference session titled Management of Aplastic Anemia, Diagnosis and Treatment. Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation using the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window. And when you have finished typing, just hit enter. We'll do our best to get to everyone's questions today. When asking questions, I do ask that you do two things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our expert speaker cannot answer any specific questions related to your health care. Our specialist today is Elizabeth Cowhay Barnes. Dr. Barnes is a hematologist and medical oncologist at Texas Oncology San Antonio Medical Center. She earned her Bachelor's of Science degree in biochemistry from the University of Texas at Austin, followed by work with the MD Anderson Cancer Center Umbilical Cord Bank in Houston. She earned her medical degree from UT Health San Antonio and completed her residency in internal medicine and fellowship in hematology and medical oncology at UT Health Science Center. Her clinical interests include cancers of the blood, non-malignant disorders of the blood, and cancer of soft tissue or bone. It's my extreme pleasure to welcome Dr. Cowhay Barnes.
Okay. Can someone hear me?
Hi, Dr. Barnes, we can hear you.
Okay, I'm sorry. Having technical difficulties after we just went through making sure everything was okay. Just to be clear, is the PowerPoint presentation on the screen?
No.
How about now?
Yes, perfect. Thank you, Dr. Barnes.
Okay, I'm sorry. I switched to a handheld microphone. So please let me know if the sound cuts out or we have any other problems. So good morning. Happy Saturday. I'm glad everybody's here joining us today. Hopefully that we're done with all the technical difficulties. And I'm Elizabeth Cowhay Barnes. I'm in San Antonio, Texas, and I'm with a group, Texas Oncology. And I am a hematologist and have been tasked with going over some information about aplastic anemia today. So we're going to be talking about first some basics. I like to start at the beginning, even if everybody on this presentation already knows some of the basics. Every clinician and physician will explain things differently. And so I like to go over some basics. What is aplastic anemia? How do you read a complete blood count when the doctor hands you your lab results? What do all the results mean? So what are some of the different things that cause aplastic anemia? Of course, we're going to go over some treatment, and then I want everybody to be fully educated on how they can be empowered to look up themselves the most cutting edge clinical trial resources available in the United States and actually outside of the United States. And so I'm not going to be going over all the details of clinical trials, but I'm going to be going over, most importantly, how patients and and their family members can have access to research the clinical trial list and how to find them on their own. And then you can have the power to then talk about that with your physician, who also has access to all this information. And then just a few other resources that can be helpful, because knowledge is power. And the purpose of this presentation is to make sure that patients have full knowledge of their disease and have all the resources at their fingertips. So let's go to the very beginning. So the word aplastic. So I've had a few patients, when I use that term, and if I don't explain what it means, they think of the word plastic, like an actual chemical structure. So no, the word aplastic or aplasia is a medical term that means failure of an organ to function normally. And then, of course, anemia, everybody's heard of that term, but we're specifically talking about a low number of red blood cells. But now this term, this aplastic anemia diagnosis, is not just limited to problems with red cells. So it's a little bit misleading. And there's problems with other cells made in the bone marrow as well. So this picture that's on the slide in front of you, on the left is a picture of what the bone marrow looks like with a patient with aplastic anemia. And on the right is compared to a normal bone marrow. So when your doctor does the bone marrow biopsies, they go down to the lab with the pathologist and look under the microscope and use their own eyes to actually look at your bone marrow cells. The information that's obtained from a bone marrow biopsy cannot be obtained through regular blood draws from a peripheral blood venipuncture. So what information is obtained from a bone marrow biopsy? So as you can see from that picture, we're looking at a few different things. So those white circles on both sides of the screen are actually fat droplets. When the bone marrow is taken out, and this is a picture of a core needle biopsy, those cells are then processed in a way in the lab so they can be put on a glass slide and looked at under the microscope. And when they do that, it actually gets rid of the fat cells. So these white spots are little microscopic empty spaces where the fat used to be. The pink blobs are actually bone and cartilage. And then the purple areas, the darker purple, are actually the blood cells that we're looking at that are made in the bone marrow. And I'm going to be talking about in a few slides what those cells are. So as you can see, as you compare the aplastic anemia slide on the left and the normal bone marrow slide on the right, there is a lot more white, which is just empty space that used to be fat, and a lot less of the purple, which are the cells that are made inside the bone marrow, which then ends up being our immune system cells, our red blood cells, and our platelets. So when we look at it in the microscope, we can see we use the term sometimes empty bone marrow or aplastic, so these less number of cells. So what are some of the cells that are made in the bone marrow that will be low when a patient has aplastic anemia, or low meaning the bone marrow is not producing them appropriately in the way they should? So one of the types of cells we look at are called neutrophils. This is a picture of what they look like, not necessarily in the bone marrow, but what we would look at from a peripheral blood stick when we take some blood out of the vein. We also can look at the blood under the microscope that way. We call it a peripheral blood smear. And we can see the neutrophils that are floating around in that drop of blood at any given time. This is what they're supposed to look like. So the DNA in the center of the cell is that very, very dark purple. And then it has all these little granules that are molecules that are made for the function of the cell. And then it's the cytoplasm, or around the DNA, is kind of sometimes a light pink color, or in this picture, more light purple. Those big blobs of a beige colored are red blood cells. And then the very, very small purple cells, the smallest one on that picture, are platelets. So let's talk about neutrophils. in medicine, we like to confuse people, and a lot of different cells or different medical terminology can go by different names. So a neutrophil is also called a granulocyte. Those are the same things. Sometimes we call them polys or segmented neutrophils. And these are cells that come from what we call a myeloid lineage, which is different from a lymphocyte. So to confuse everybody, sometimes your doctor, well, not on purpose, but it could be confusing if your doctor is talking about these neutrophils, but they may be using different medical terminology. They may be talking about myeloid cells. They may say the term granulocytes. They may say segmented neutrophils. All of that just means the same thing. And how is this reported on a complete blood count? So every time you go into your hematologist or medical team, a lot of times they will do a basic venipuncture blood draw and get a complete blood count or a CBC. And as you know, there's about 20 different measurements that come back on a CBC with differential. And how we measure the neutrophils will come back in two different lines on that complete blood test. One of them is a ANC, which stands for absolute neutrophil count. And this will be reported in a number that usually has a number sign next to that particular value. And then there will be another one under it that says a percentage. So really what I want you to focus on is not the percentage, but you're going to focus on what says an absolute neutrophil count. And it usually, like I said, has that number sign or hashtag next to it. So these neutrophils, what do? Why are they important? So they're one of the many immune system cells in our body, and these help us fight infections, specifically usually by engulfing organisms. So we have different ways our immune system fights infections. There's other cells that make antibodies. There's other cells that fight organisms in different ways. But these neutrophils tend to be the most important for fighting certain bacterial infections and fungal infections. So what is considered a low number? Now, in the beginning of your journey, I'm sure many people started looking at when you got a report of your complete blood count, you'll see that there's something called a reference range. And that's the quote normal values, and there will be a low number and a high number range, and your numbers would be outside of that range. And remember that that reference range is actually just a statistical value that is taken from a large number of quote normal patients at any given time, and they can have a particular number of neutrophils or any other lab value within that reference range. But if you're outside of that reference range, it does not necessarily mean there's a diagnosis of a medical problem going on. Our immune system varies for many different reasons, as well as some of these other cell lines. So you would ask your doctor to explain if it's outside of that reference range, but they don't seem especially concerned or tell you not to worry about it. There's a reason for that. And again, if it's outside of the reference range, it does not necessarily mean it's a medical diagnosis or problem. But going back to aplastic anemia, there is a problem with the number of neutrophils. And specifically, these are going to be low because your body is not making them appropriately in the bone marrow in normal numbers. So when it comes back on your complete blood count, it will be given in a range. Now they're in thousands. So your exact number is either going to be in as I have listed on the PowerPoint slide, in a range that will be either 500, 200, 100, or it can come back in a number that's written as, say, 0.5. That is the same thing as 500. Okay, so it's in thousands. And so just understand that whichever lab you're getting your labs tested at, 0.5 is the same as 500 when we look at these lab cells, values for neutrophils. Same thing if your number is 1.0, that's the same thing as saying 1,000. So I hope everybody's on the same page. Now, so what's considered a normal number of neutrophils? Now, usually we say over 1,500 or 1.5, depending how that reports on your particular lab where you're getting your labs done. But when it's less than 1,500, again, that does not necessarily diagnose a serious medical problem. When the neutrophil count gets into the 500 to 1,000 range, that's when people's immune system can start having problems with fighting infections. We would call this a mild range, but there could be issues with being able to fight off certain infections. A moderate decrease is if the neutrophils are 200 to 500, and then severely decreased, where we say you have a very low immune system, is when they're less than 200. And so, yes, we would be very happy to get the neutrophils completely within the normal range and have a normal number. But there is also a really big difference if your neutrophils are initially 100 and we're able to get them up to 800. That is actually success in treatment and does help your ability to fight off infections well. So it's not an all or nothing, it's a range. And please talk to your doctor about what would be the goal for you and what's best for your individual case of where your doctor wants your neutrophils to be with treatment. So let's move on to a different type of cell that's made in the bone marrow. So these are the red blood cells. In this particular slide of a peripheral blood cell, now the arrows are actually pointing to platelets, but the red circles, some people say they look like donuts, or the circles with the area of white are called central pallor. Those are what our red blood cells look like under the microscope. Now, these red blood cells are pretty healthy. Actually, this is a good number. They're nice and red or nice and pink with not a lot of white on the inside. So this is what they should look like when everything's functioning normally. What do red blood cells do? Why are they important? So they carry oxygen from our lungs to tissues and our organs. So oxygen carrying cells. When you're low in hemoglobin or low in your number of red blood cells, which is saying the same thing, then your body has a harder time carrying your oxygen around your body and delivering that oxygen to the tissues that need it. So how is this reported on the complete blood count? So there's quite a few different values that describe different components of your red blood cells on a complete blood count. Some of them are actually giving the direct amount of how many red blood cells you have. And those are 3 different values. One of them is the RBC, which stands for red blood cell. That's really a mass of the red blood cells measured by the computer. And then there's another term that we use, so hemoglobin, and it's usually abbreviated HG on that complete blood count, or hematocrit, which is abbreviated HCT. And I'm going to speak in terms of hemoglobin. Usually when we talk about and your doctor's talking about your goal of where you want your number of red cells to be and what's low, normal, high, and making improvements with the number of red cells, we're going to be talking usually about hemoglobin. I'm not going to talk about the different other numbers that are on a complete blood count that have to do with red blood cells. The other ones are measuring really the size of the cells and the variation in the size. You can ask your hematologist to explain those. But the most important one that you need to be familiar with, that you understand for your case, is the hemoglobin. So when we're low on our number of red blood cells or low in hemoglobin, that's called anemia. And it makes us feel bad. We feel very tired. Our skin gets pale, or our lips get pale, or underneath our fingernails. We can feel dizzy, especially when we go from sitting to standing or have been lying down and standing up quickly, like say in the middle of the night to go to the bathroom. Or especially if you're exerting yourself and needing to use more oxygen, such as walking up flights of stairs or trying to walk down the street to the mailbox or trying to get some exercise, you're going to feel like you're huffing huffing and puffing more because your body's trying to get more oxygen in, but you have then a hard time taking that oxygen that you're breathing in normally through your lungs and carrying it quickly to the tissues that need it during those periods of exertion. So a normal hemoglobin actually varies a little bit based on age, whether you're a menstruating female or gentleman. But for most people, we would say a hemoglobin over 12 should really have very few symptoms and is for the most part considered normal. Again, please ask your doctor what is a normal hemoglobin for you. But for most people, people are going to feel pretty good or few symptoms if a hemoglobin is greater than 12. Now, when a hemoglobin is between 10 and 12, you can start to have some symptoms. You may be fine when you're just sitting down, but if you're really starting to get your heart rate up, exercising, periods of exertion, you can really start huffing and puffing more and feeling it, where you don't quite have as much energy with activity as you would have before. When the hemoglobin is 7 to 10, again, people have even more symptoms that I'm describing. Less than 7 is a cutoff that we usually use for where we start to worry about the organs and tissues really getting enough blood long term. Now, if the hemoglobin drops less than 7, it's not an immediate emergency that has to be addressed, over the next few hours, but we do consider blood transfusions when the hemoglobin are less than 7, more long-term, something we want to correct that to help protect organ function so you don't develop another problem. So I'm sure most people on this call are familiar with needing red blood cell transfusions or different things that your doctor's focusing on to try to increase your hemoglobin numbers. And we can talk about that if you have questions at the end of the talk. So platelets are another cell type. So what do platelets do? So they help our blood clot and stop bleeding when a blood vessel is injured or damaged. So they're usually, they're made in the bone marrow by cells called megakaryocytes. And then a mature, normal working platelet will then leave the bone marrow and travel around in our bloodstream. And not activated until our body needs it. But when we have some sort of injury, bleeding needs to stop, then the platelets become activated, they clump together, and then they help us stop bleeding. So what happens when the platelets are low? So it increases our risk of either spontaneous bleeding or if we have an injury of not being able to stop the bleeding. And this can include a very minor injury, such as if you bump your hand against a table, you may develop a bruise when you wouldn't have normally depended on what your platelets are. So a completely normal platelet count is 150,000. But really, we don't start treatment or really start to worry about bleeding risk until the platelets are less than 50,000. So again, I'm going to keep saying this throughout the presentation, but I'd like for you to talk to your doctors on what is a good platelet count for your particular body in your particular situation. Now, some patients have to be on aspirin or they need to be on blood thinners for some reason, and that your platelet count may need to be higher. Menstruating women. So you may be losing blood during your menstrual cycle each month and bleed too much, which can worsen the anemia problem. So we may want your platelets higher for you. So there's different ranges on what we think is a quote good platelet count for each particular person. But as a general rule, we usually say platelets between 50 to 100,000 have a mild bleeding risk. You may bruise easily, but you should be fine walking around in your everyday life, and we don't worry about you. When the platelets are between 20 and 50,000, the bleeding risk increases. Again, that may actually be a good number for you when you're walking around in your everyday life and your doctor say, oh, your platelets are 30, they're fine, we're happy, and that's fine. So again, it's a personalized goal for you. Now, when platelets are less than 20, that's when we do start to really counsel patients about increased bleeding risk. And less than 10,000 is when that risk is most severe, and we give platelet transfusions. Now, a platelet transfusion doesn't last very long, really about 3 to 4 days if we're lucky. So the purpose of platelet transfusions is, if it's less than 10,000, to just boost that number up of platelets from a donor, from someone else. They'll circle around in your bloodstream, and then they'll be filtered out by our spleen or other mechanisms as they would. So they just don't last very long. Our body should make platelets every single day continuously from our bone marrow, and then they get filtered out by our body every day. But the problem, of course, is the function of the bone marrow. So that's why people have low platelets. So what causes aplastic anemia? I went over a lot of details about, what it is. The bone marrow is not making these cells, and the cells we worry about are the neutrophils, the red cells, and the platelets. But why did this happen? And there's different reasons. So the most common one is what we call immune mediated, or we also can sometimes use the term idiopathic. That really means we don't know why this was triggered, but we believe it's a problem where something went haywire with your body, where your own immune system that should be able to tell the difference between an invading microbe that it needs to attack and kill and our own good cells in our body, something went haywire where the immune system is no longer able to tell the difference between a good cell and a bad cell. And it starts attacking these cells in the bone marrow, thinking they're bad when they're not, but it leads to then the bone marrow not being able to produce the cells because our own immune system, specifically T cells usually, are the ones doing the attacking. So we call that immune mediated. And in adults, this is the most common type, about 70%. Now there's a more rare type that's called PNH, paroxysmal nocturnal hemoglobinuria, which I have one slide talking about as we go forward. Now there's some other more genetic issues that we would call inherited causes, where people inherit some abnormal genes. And there's actually more than what's on this slide. And through the years, we've discovered that there's actually more and more underlying genetic component to this than we used to realize. Now, in one of the resources I'm going to be talking about at the end of the presentation, some patients, really want to know, how do I get tested to see if it's an immune mediated cause or an underlying genetic cause? So please, of course, talk to your own hematologist, but these special genetic testing, it's not something that's done at most labs or most hospitals. It has to be sent out to a specialty lab, really understanding that we're testing for these genetic issues related to aplastic anemia. And a very good resource is actually, you could call the Aplastic Anemia MDS Foundation, who's sponsoring this talk, and there's some navigators, and they can give information about sites across the country that will do some special genetic counseling for each individual case and testing for some of these things. I will say, even as a hematologist, in the San Antonio community, sometimes I struggle trying to find the right lab to do these that's in each patient's insurance. So I rely on the Aplastic Anemia MDS Foundation to help me as well get these processed. So just names of some genetic diseases that can lead to underlying aplastic anemia. So there's something called telomere diseases. Again, it's been relatively over the last few years more understood. And so there could be patients who had been diagnosed 15 years ago that we didn't know the reason and could actually be a telomere disease. And then there's some more that tend to come up more with pediatric patients or young adults, but something called Fanconi anemia, Diamond-Blackfan anemia, and then there's some other underlying genetic components. So on the other side of the screen is a group that we call secondary aplastic anemia. So this means that the bone marrow in itself was actually intrinsically healthy and something came in to damage it. And this can be most commonly with infections. And then when we treat the infection, get rid of that thing that was doing the damaging, then the bone marrow can return back to normal with time. But sometimes it doesn't. So sometimes it was an infection that caused the damage. It can be medicines, it can be toxins. Now, going back to the infection, one of the most common ones is after a bout of hepatitis, but there's different, of course, many different infections that can cause it. Now, people that have other underlying autoimmune diseases, specifically lupus, some severe rheumatoid arthritis, for the same reason that I talked about the immune mediated, the bone marrow is really just another organ in the body. And if someone has a systemic autoimmune disease that's attacking multiple organs, the bone marrow can be another organ that's affected by the underlying lupus or different autoimmune diseases that are found on workup. And then lastly, pregnancy. We don't really understand the full pathophysiology of what happens during pregnancy, but we think this is really still an immune mediated problem. And sometimes just delivering the baby itself and having your own immune system go back to normal can reset and fix the problem. So this is talking just a little bit more about the most common type, this immune-mediated destruction causing neoplastic anemia. As I mentioned before, it's primarily a problem with T cells that are attacking the bone marrow. These T cells are another way our body fight infection, but when the T cells start attacking whatever it is that they think is abnormal and they need to get rid of, then it leads to an increase in other cells and things called inflammatory cytokines. And then eventually those bone marrow cells get killed, which if it's an invading microbe, that's exactly what we want these T cells to do. We want them to attack whatever that bad thing is, increase these inflammatory cytokines and kill whatever the bad thing is. But when it's happening in the bone marrow and it's our good normal cells, that's what's something's wrong. And it's then leading to the diagnosis of aplastic anemia. So this is my one slide talking about paroxysmal nocturnal hemoglobinuria. And I think there may be a whole nother presentation on, so people that have full PNH without aplastic anemia, that actually is a different disorder where the bone marrow is working fine, but as the cells get into the peripheral bloodstream, different parts of the immune system are then attacking them, and which we call hemolysis. So the bone marrow functions fine. It's just when they're floating around in the blood, the red blood cells get broken down prematurely. So again, hemolysis. So paroxysmal nocturnal hemoglobinuria is a syndrome where three different things happen. And you become anemic, but it's because of this issue called hemolytic anemia, which leads to the red cell destruction after they're already formed appropriately. For other reasons, which is different from aplastic anemia, patients also are at a great risk of developing a clot, which we call thrombosis. And then eventually, as paroxysmal nocturnal hemoglobinuria worsens, it can lead to then problems with the bone marrow and aplastic anemia. So this disorder is different. This is not an immune mediated problem, as I discussed earlier, of the problem with the T cells. So this is a problem where the body cannot make a protein called a GP1, or it's an anchor protein that is supposed to attach molecules to the surface of a cell. And specifically, the proteins are called CD59 and CD55, and the CD stands for cellular domain. And so when red blood cells do not have these particular anchor proteins, then there's other molecules that cannot be attached to the surface of the red blood cell. And those molecules usually protect the red cells from destruction from the immune system. They're markers to the immune system to say, hey, these are our normal cells, leave them alone. They're supposed to be there. But when they lose these markers, the immune system thinks again, there's something bad, that they're not supposed to be there. And then a different part of the immune system called the complement system is responsible for then coming in and destroying the red blood cells. So some patients with aplastic anemia can have a small percentage, or what we call a clone of cells in their bone marrow that come up positive for these red blood cells that don't have the anchor protein on them. Now, a very small percentage of if there is a small number of these cells in the bone marrow that have this P&H clone, that does not actually lead to a full diagnosis of P&H. So we don't treat it the same way as P&H. We treat it as aplastic anemia. Now, there are patients who have a large number of these cells that are lacking these anchor proteins. Now, if that's the case, then that actually means your diagnosis is P&H and not aplastic anemia. The P&H has led to aplastic anemia, and then we can use it to treat medicines that inhibit or decrease the complement part of the immune system, which is the part that's attacking the red blood cells. An example of a name of a medicine is eculizumab. It also comes in a different variation now, made by the same company, that lasts a little bit longer. And then there actually is another medication that's been introduced last year to treat P&H. So there may be a whole nother discussion on P&H. It's a different disorder, so I won't go into that further. This picture right here just shows why it's called paroxysmal nocturnal hemoglobinuria. And for patients with this disorder, their urine color changes throughout the day. So that 7 o'clock time period where it looks the most red, it's the most red blood cells getting broken down. But you can see by night, by 7 p.m. at night, the urine's actually clear by that point. And so the red blood cell hemolysis, or red blood cell destruction process, changes throughout the day. So it doesn't only happen at night necessarily, but that's why it's called nocturnal hemoglobinuria, that you're urinating out these broken down red blood cell components. So let's now talk about treatment of aplastic anemia. So I went over what is it, I went over some causes, I went over just some very basic but fundamental information I want you to know about how to read a complete blood count report. So now let's talk about treatment. So the very first decision that your doctor's making after they get the diagnosis and trying to figure out what caused it, if you fit into this idiopathic or immune severe aplastic anemia category, and the doctor thinks your cell numbers are low enough where you need to start treatment to try to fix it, one of the first decisions that's made is should you go to a bone marrow transplant initially, or should we initiate immune suppressive therapy, which I'm going to be talking a bunch about. Now, it tends to be, this is a conversation for adult patients. I am an adult hematologist. Most every patient would go to immune suppressive therapy as an adult. If it is known that the cause of the aplastic anemia is due to one of these underlying genetic syndromes, then we really do, the immune suppressive therapy won't work, because the immune system is not the problem of why it happened. It's an underlying genetic problem. And so then we tend to send the people with the genetic problems to a bone marrow transplant, and the people with the immune mediated causes to the immune suppressive therapy. Now, there's a whole nother talk about bone marrow transplant with aplastic anemia and myelodysplastic syndrome later today. So I'm not going to be talking too much about that. If you have questions about a bone marrow transplant, please stay tuned and sit in for the whole hour-and-a-half visit with Dr. Norruden, I believe, talking about bone marrow transplant. Okay, so let's talk about immune suppressive therapy. So this is the initial treatment when we believe the aplastic anemia is due to this abnormality or problem where our immune system is attacking the bone marrow. So first, of course, we have to look at, does the patient need treatment right now? Is it appropriate to just monitor and see what happens in the future? And that depends on how low the neutrophil count is, which leads to risk of infection. Of course, how low the red cells are, how low the platelets, and are you needing transfusions to survive? And if you are, or you're very low neutrophils and high risk of infection, your doctor will say, okay, you need treatment. You're too high risk. So the initial medicines we use is a combination of 3. The first one is given usually in the hospital right at the time of diagnosis. It's usually given as 1 course, but can sometimes be repeated a second time for certain patients. And this is called anti-thymocyte globulin, ATG. The next medicine that's used, also started at the same time in the beginning, is cyclosporin, which is an oral medicine. And then the third medicine that's commonly added now is elthrombopag. So I'm going to be talking about each one individually and why we use them together as this combination of 3. So anti-thymocyte globulin is a very interesting medicine and molecule. It's actually quite complicated to make. It's created by injecting human immune system cells, specifically these type of white blood cells called a T lymphocyte, into a horse or a rabbit. And then that particular animal's immune system, the horse or the rabbit, recognizes these particular T cells as something abnormal, and it creates antibodies against those human T cells, which are not normal in that animal's body. It's something wrong, it's something different. And so they make antibodies, and then they take out these antibodies that are produced in that animal, and then they create a serum, and it's a particular medicine that can be infused into a person. So again, you may hear of it as called either horse ATG or rabbit ATG. We tend to use horse more commonly, but there's reasons to use one or the other, which I will defer to your hematologist of why they pick one. So this anti-thymocyte globulin works then, which is fundamentally an antibody produced by the animal, to then go in and kill specific T cells in your immune system. So the T lymphocytes. So it's those T lymphocytes that have gone haywire and are attacking the bone marrow cells. So we're using these antibodies made by the animal against human T cells that then learn and say, hey, this is something bad, we need to get rid of it. So these T lymphocytes are the cells that are attacking your bone marrow stem cells. And when we get rid of those abnormal, non-functioning T cells, then hopefully this allows your own bone marrow to rebuild and regenerate and start making all your blood forming cells that you need. So anti-thymocyte globulin is usually given as an intravenous infusion that's about for 4 to 12 hours a day for 4 days in a row, again, in the hospital. There's some specific side effects, something that we call serum sickness. So these antibodies from the animal are not a protein that's normally made in your own body. And so getting high fevers or rigorous shaking, chills, and a rash is a common side effect that happens during the ATG infusion. So it has to be given in the hospital and with close monitoring to get you through the treatment and control all the side effects safely. So the next medicine is cyclosporin. So completely different medicine, works in a different way. It's also called Sandimmune as the brand name of it. So when used alone, without cyclosporin, the ATG by itself will improve the blood counts to the point where people don't need transfusions anymore, about 50% of the time. And so when we add on cyclosporin to the ATG treatment, and this can improve blood counts usually about 70% of the time. So if it works, ATG usually then stops the need for transfusions, but even though it's given over 4 days, it takes a long time for these medicines to fully work and get their full effect. So we usually say you need to give it at least 3 to 6 months, but full recovery can actually take a year or more for the stem cells in the bone marrow to completely recover. So cyclosporin is an oral medicine. It's taken every day, and it also works of decreasing the action of these T lymphocytes, these T cells that are abnormal, but in a different way from the ATG. And so these are pictures of different forms that the cyclosporin can look like depending on the manufacturer. It can also come in a liquid. It's usually taken twice a day. So the third medicine is L-thrombopag, or also called Promacta, which is the brand name. So L-thrombopag is an oral medicine that's taken once per day, and it does not affect T lymphocytes. It works differently. So it's called a thrombopoietin receptor agonist, and it stimulates a type of cell in the bone marrow that leads to production of some of the myeloid or neutrophil cells, and then megakaryocytes or cells that make platelets. So a thrombopag really doesn't have too much effect directly on the red blood cell lineage, but it signals to the bone marrow, make more of these types of cells, and eventually that's the lymphocytes and the platelets. So it's an oral medicine. It's taken once a day. It is important that it's taken on an empty stomach because food greatly affects the absorption of it. And there's clinical trials to prove how medicines work are multi-year, ongoing. We come out with some information and then we get more information, more information, more information. And so actually, just in January of this year, there were results from studies that had been ongoing for many years with L-thrombopag and severe aplastic anemia. And the New England Journal of Medicine released the results just in January of the most updated research of this medicine, of how it works. And so I'm going to try to do something fancy. If it doesn't work, bear with me. I'm just going to talk about this study. But the New England Journal of Medicine website has some videos for patients that explain how this medicine works. So I'm going to go to the New England Journal website, go to their video. Let's see. Oh, let's see, here we go. Oh, no, of course. Well, so this is the New England Journal of Medicine website. It does make you sign in and create an account, but it's free. And they're not going to send you a bunch of spam information. And so this is what it looks like on their main website. And there's a video that they just created, like I said, 2 months ago, to explain to patients the results of this particular research study of how L-thrombopag works in severe aplastic anemia. So I'm going to make this bigger, and the video is just 2 minutes and explains the results of the research studies.
Patients with severe aplastic anemia are typically treated with immunosuppressive therapy, comprising horse antithymocyte globulin plus cyclosporin. An early single-group trial suggested that adding the oral thrombopoietin receptor agonist L-thrombopag to this regimen could improve outcomes, but further research was needed. In this phase 3 prospective multicenter open-label randomized trial, 197 previously untreated patients with newly diagnosed severe aplastic anemia were assigned to receive intravenous horse ATG plus oral cyclosporin, either alone, Group A, or with the addition of oral L-thrombopag, Group B. The primary endpoint, hematologic complete response at 3 months, occurred in 10% of the Group A patients versus 22% of the Group B patients. Secondary endpoints included overall response at 6 months and median time to first response. Again, results were better with L-thrombopag than with standard treatment alone. Adverse events such as infectious and hepatic complications were comparable in the two treatment groups. The authors conclude that among patients with newly diagnosed untreated severe aplastic anemia, adding eltrombopag to standard immunosuppressive therapy increased the rate of hematologic complete response at 3 months and the overall response rate at 6 months, without increasing toxic effects. Full trial results are available at nejm.org.
Okay, very good. So just to reiterate what we were talking about when we were talking about response to treatment, as that video went over, they talked about something called a hematologic response and complete response. And so by adding eltrombopag to treatment, actually you do want to continue the treatment on for at least 6 months, because there was a great improvement. They measured how many patients had that response at 3 months, how many at 6 months. And then just to be clear, actually, there's patients who continue to get a response and will get this desired hematologic response even past 6 months. They just had those two endpoints in the trial just to measure what happened at 3 months and 6 months. It doesn't mean if it doesn't happen by 6 months, you're not going to recover. That's not what that means, just to be very clear, but they had to have a set data point to measure in a research study. So the term hematologic complete response means a hemoglobin greater than 10, an absolute neutrophil count greater than 1,000, and a platelet count greater than 100,000. Now, as I went over, yes, those numbers would be wonderful, and that's called a complete response, but there's still a big improvement in patients who go from a hemoglobin of 6 to a hemoglobin of 9, and they're no longer needing transfusions. They may not have met that endpoint of a hemoglobin greater than 10, but clinically, you feel a lot better. You're not needing transfusions. I mean, the treatment has worked, and we actually call that a partial response, meaning you're not at this point yet, but you're no longer needing transfusions. And the hope is that, again, with time past the 6 months, that it will continue to get better and better and better. So I'm not going to spend too much talking about transplant. I just have one slide. I just want to be very clear that when we're talking about transplant for aplastic anemia, we're talking about something called allogeneic hematopoietic stem cell transplantation. Allogeneic means the cells are coming from a different person, so not your own cells used, because there's a problem with the bone marrow cells, and so we don't want to use your own. So this also is called a bone marrow transplant. And the goal is to get rid of the sick stem cells and replacing them with healthy stem cells from someone else. So many factors are considered when we're trying to figure out should a patient have a bone marrow transplant or not. The age of the patient, the health of the patient, do they have other underlying problems? A bone marrow transplant process causes a lot of physical stress on the body, and someone's organs have to be functioning well in order to take that stress to go through that whole process and then come out healed and well at the end. But it's a process. So people who have underlying severe kidney problems, liver problems, heart problems, their own body would not be able to handle the physical stress that would happen with a bone marrow transplant. And then we look at how closely matched are the donor stem cells. And that can make a decision on whether a patient decides to proceed with a bone marrow transplant or not. So the best match is usually a brother or sister, a sibling. So there's about a 25% chance that a sibling will be an appropriate match. But as we get older, especially usually over the age of 50, it's very difficult to find a sibling who's a good match, who doesn't have other health problems themselves. So sibling donors are best if that is a situation you're in, that's wonderful, but used a little bit more commonly in the pediatric and young adult population. If you don't have a matched sibling, it doesn't mean that you're out of luck. We look at unrelated donors, and then more and more and more, there's better technology to have a bone marrow transplant be successful with even up to half matches. So stay tuned for the bone marrow transplant talk, because there's a whole hour and a half. talking about details with that. Why does it matter if you have a matched donor? So two things can happen. So if it's not well matched, then your own immune system cells can attack those new stem cells and make them not work. That's called graft rejection. The opposite can occur where if they're not matched, then your new stem cells, your new immune system that came from the donor can then start attacking other parts of your body that it recognizes as not normal. And that's called the graft versus host disease. So two things, your own immune system can attack the new cells, or the new cells can attack your own body. And so the better the match, the less chance of those bad things happening. Okay, so these next few slides are changing gears, and it's going over information that I want all of my patients with any type of underlying clinical problem really can use this. And it's having access to the databases for the most up-to-date cutting edge clinical trials. So the website you go to is clinicaltrials.gov, and you can do this. You don't have to be a doctor. You don't have to be a researcher. This is public information, and it's really not hard to navigate once you know what website to go to. So I have a few screenshots of examples of what it looks like to navigate through the website, just to give you an example of why we're doing this. So this is when you go to clinicaltrials.gov, and you actually don't have to create an account. Anybody can do this. Just public search. And this is the first screen. So again, clinicaltrials.gov is a database of all public and privately funded clinical trials really throughout the world. So it's sponsored by the US National Library of Medicine. But it does not mean these are only government-sponsored trials. Any legitimate clinical trial that we want our patients to participate in will be listed through clinicaltrials.gov. So this is your most reputable resource. And on this right side of the screen, you'll see Find a Study. And so you can either search by all studies that have closed, or click the recruiting or not yet recruiting studies. Recruiting means they're actively accepting patients. All studies, it'll still be listed even when the study is completed and over. And so the time you usually want to click on recruiting studies. You can either search by typing in aplastic anemia or any other condition, myelodysplastic syndrome, acute leukemia, lymphoma, whatever the case is, into the condition or disease. And then you can search. There's a different way to search by country, but you can type in aplastic anemia at the top and then put the United States. And then you hit the search button. And so I had typed in exactly that. I had put in aplastic anemia, United States. And this is what comes up. It's a list of, you'll see a total of 54 studies. And then I had clicked the button that says recruiting. So ones that are actively, oh, and I'm sorry, actually, this was all across the world. So there were 54 current studies open looking at patients with aplastic anemia across the world. Now you can see on kind of the middle left-hand side of the screen, it lists, there's these little tabs, folder tabs. And if you click on the On Map tab, then it would take you to this screen. And so you could see that depending what state you're looking in, there's currently 5 that are open in the state of Texas, but different ones in states across the United States. So then I clicked on the ones that are available in the United States. And this is what the list would look like. And so there would be 7 different studies that I wanted to highlight for this particular presentation, but you have access to go to clinicaltrials.gov, do this on your own, type in situations that may, there's a way to search based on age. So you're filtering out pediatrics or over 60 or something that filters out bone marrow transplant or not bone marrow transplant. And so this is the list that comes up. And then under that section that says study title, you then click on it, and then it will lead you to information about the research trial. So I clicked on that very first one, Natural History of Acquired and Inherited Bone Marrow Failure Syndromes, and it will lead you to this screen. So this is a study I would like everybody to be aware of and consider participating in if, of course, this is something you would be interested in doing. And this is run by the National Institutes of Health in Bethesda, Maryland. And it's the biggest study that's going on collecting blood samples and sometimes bone marrow samples from patients with aplastic anemia and other bone marrow failure syndromes to really understand a lot more about how many of these are genetically related, what causes them, just trying to understand a lot more about this disorder. And so you would scroll down. This is only just the first initial snapshot of what comes up on the website. But please look at this, see if it's something you'd be interested in participating in. Usually it does mean going to the National Institutes of Health in Bethesda, Maryland to participate. Sometimes they do pay for travel for patients who participate in their studies, so airline and hotels. And it's usually then a visit about once every few years. Or if you're interested in a second opinion by some of the world's experts in bone marrow failure syndromes, then the National Institutes of Health in Bethesda is one of the very top places in the whole country. Now, this is just an example, this next slide of, let's see, when we go back, you can see on number 2 what happens if we click on number 2, and this is a different trial by a company called Regeneron. So this is switching gears. So this is a pharmaceutical company sponsored clinical trial. It is only available in Cleveland, Ohio in the United States. It's actually quite a lot of sites across the world, in France and in Asia. But this is looking at a different molecule called anti-leukin-2 receptor subunit gamma in patients that have severe aplastic anemia who they already had the immunosuppressive therapy. They're not going to have a bone marrow transplant and they need something else. So right now, when I searched actually on Wednesday, this was the list of available trials, but you can search yourself and each month, some different trials maybe become available. This is an example of another one that's very interesting. So it's looking at a drug called sirolimus, also called Rapamune, also for patients who have severe aplastic anemia who have already had immunosuppressive therapy, and it did not work well enough, and we need another treatment. So this is a treatment study in Bethesda, Maryland at the National Institutes of Health. It's for children and adults, and it's really exciting, and this may fit a treatment option on some patients who are in this particular talk today. And then lastly, this is my last slide before we get into the question and answer session. I just, of course, want you to know that if you haven't already used the Aplastic Anemia Myelodysplasia Syndrome Foundation websites, and it's, I'm sure you know that it's on this, it's the aamds.org, but there's a lot more information. There's patient guides, there's recorded webinars by other experts on aplastic anemia. There's a whole podcast series. The podcast tends to be more on the myelodysplastic syndrome, but they still have some episodes related to aplastic anemia. There's recorded lectures, there's a support group, there's other links. Please check it out. And thank you.
Thank you so much, Dr. Cowhay Barnes, for the wonderful presentation. We have some questions. So our first question is, if the bone marrow is producing immature red blood cells that make it out of the bone marrow, do their hemoglobin content get counted in a CBC, even though the hemoglobin does not reach organs and muscle?
So yes, well, so a reticulocyte is the marker for immature red blood cells that are produced in the bone marrow. And this is actually a really good sign. You want a higher number of reticulocytes because it's a marker that the bone marrow is starting to work, it's starting to function and making these cells. And then it is a process of then the reticulocytes, which are immature, not fully functioning red blood cells yet. They have to go through a little bit more development to be a mature cell or grow up, as I sometimes say. But having an increased number of reticulocytes is a good thing because the bone marrow is starting to recover and function. So that's not a bad thing.
Thank you. Is there a role for GCSF in aplastic anemia, and when would you give it?
There, can you hear me now? Sorry, I don't know why it muted me.
Yes.
There we go. So there is a role. So GCSF stands for granulocyte colony stimulating factor. And it's a medicine that, remember I went over when we're talking about neutrophils, they're also called granulocytes. And so usually these medicines that try to stimulate the granulocytes to be more active, to make more mature neutrophils, they don't work well in most types of severe aplastic anemia. So it's not something for all cases where we give GCSF, just mainly because it doesn't work. The problem is the immune system is attacking the granulocytes so much in the bone marrow that it doesn't matter if you try to stimulate them more. It's not going to be effective. It would not hurt, but it's not very effective. Now, that being said, there's certain bone marrow failure syndromes. This is a constellation. This is a group of disorders that are caused by different things, and we're not all the same. And so you could have a type of bone marrow failure or aplastic anemia where the granulocyte stimulating factors, the GCSF, would be beneficial and would help the stem cells in the bone marrow to make more neutrophils. So it's very reasonable. We do use it. There's a role, but it doesn't work for everybody, and it's not a one size fits all.
Thank you. Our next question is, how would you address mouth sores on gums?
So that is caused, unfortunately, when the immune system is very low and these neutrophils are very low. One of the bad things, besides being able to fight off infections, what happens is we develop irritation and sores called mucositis, inflammation of the lining of our mouth, down our throat, our intestines, which is called the mucosa layer. So inflammation of the mucosa, mucositis, and then that's the mouth sores they're talking about. So we don't have really good treatments that directly fix the mucositis. The best fix of the mucositis is to improve the neutrophil count, treat the underlying cause, but there are some supportive things that can be done. I'm sure your doctor has already talked about the not very effective medicines, which is just topical lidocaine or Maalox, which just helps get rid of some of the acid that's in our mouth, and sometimes Benadryl, which can decrease some of the inflammation. So there's these oral combination medicines called triple mix or magic mouthwash. They're only partially effective. It's really just putting a Band-Aid, some lidocaine, to try to make it not hurt so much. The other things is there are some other mouthwashes that help the saliva production and just protect the lining, again, act a little bit like a Band-Aid. But there has been some research, in fact, I was involved in it during my training, that increasing protein intake and nutrition into our system actually matters a lot. Now, that's difficult because you don't want to eat because your mouth hurts. I understand that. And so it just makes it where you just don't really want to eat. But focusing on good nutrition and specifically protein actually does help the mucositis. The research that I did was looking at increasing patients' protein intake prior to a bone marrow transplant and seeing if that had an effect on them developing mucositis, and actually trying to increase their protein and nutrition did lead to better outcomes with that. But we're still waiting on an even better treatment than those supportive things I said, because it can be quite miserable, I understand.
Thank you. Our next question is, can you start ATG, cyclosporine, and L-Traumapag at the same time?
Yes, ideally they should be started at the same time, though in how the real world works, usually the ATG is ordered by a hospital pharmacy. So you're admitted in the hospital overnight. It's relatively at the beginning of the diagnosis of aplastic anemia. You had the bone marrow biopsy. This is all new. You're frantically searching online and your loved ones to get more information about this. And the ATG is used usually right in the beginning. And then the L-Thrombopag usually has to be ordered and is not carried by the hospital. So we have to order it, get approval from the insurance company, and then start it. So yes, they can be started absolutely at the same time on the same day. But if there's a delay in about a week apart from starting each other, as soon as possible together.
Thank you. Is tacrolimus a substitute for cyclosporine?
Yes, it is. It is another immunosuppressant medicine that is used commonly to suppress T cells. Correct. And there may be one reason the cyclosporine can have some effect on eyesight. So that's one of the toxicities, or kidney function. And so the cyclosporine levels are checked about once a week or every couple of weeks till we make sure patients on the right dose for their body. And there could be reasons to substitute the tacrolimus one for the other. Yes.
Thank you. What is the difference between the diagnosis of moderate aplastic anemia versus severe aplastic anemia?
So that's based on how low the blood cells are. And so we categorize them looking at the number of neutrophils, the hemoglobin, and the number of platelets, and then put them into categories for mild, moderate, severe. And it's just the numbers are lower on the severe, kind of middle for moderate, low, they're still low to have a diagnosis of aplastic anemia, but mild. And so it's really getting back to what I was trying to hit home, that not all the cells have to be back into the complete normal range to be an improvement for your case. And so for a patient to go from the severe to the moderate range, that's actually good. The treatment's working. That usually means not needing blood transfusions as frequently.
Thank you. Our next question is, at what point do you reach the maximum improvement that you would see through immunosuppressive therapy? Can you still see improvement after a year, but after 18 months, does it level out?
So you still can continue to see improvement after a year. I counsel patients that give it at least a year. Now that 3-month and 6-month endpoints that are used in research studies is really just because we have to arbitrarily pick a time period to look at. But even I have patients who have continued to make improvements even past a year. Yes. And so it can continue to get better. Immunosuppressive therapy can continue to help. But if you're in a category where after a year, you're still needing relatively frequent blood transfusions or platelet transfusions, that is in a category of not appropriately effective and need to think of some other treatment options available. If you are in a category where your blood cells have improved enough where you're not needing blood transfusions, and so kind of getting into that moderate from the severe level, then it's very reasonable to continue the immunosuppressive therapy even past a year and see if there's any ongoing improvement from there. This will be our last question.
The patient is suffering from severe muscle cramps, predominantly at night. They take 100 milligrams of Aplastic per day. They like to know, is this common and what can be done to help in this situation? They lead an active life in spite of having aplastic anemia and are physically fit.
So I would not say that severe muscle cramps are necessarily something that goes along with aplastic anemia as a whole. That being said, sometimes bone aches, feeling tired, there's a lot of the kind of vague symptoms of body aches that people can experience. I'd be interested in this particular patient if they are on any of those granulocyte stimulating factors, so that can cause some of the muscle aches. L-thrombopag, it doesn't usually, but it can be one of the side effects. And so making sure that there's good electrolytes, that the vitamin D levels are normal, checking the iron levels is very important. Either too high or too low iron levels can affect muscle cramps like this. So there's a lot of different things that's really just outside of the aplastic anemia that need to be looked at to see if there's any improvement. Is this true restless leg syndrome? Is it muscle cramping from electrolytes? Is it muscle issues because of protein issues or damage to the muscle due to neuropathy from prior medicines? There's a lot of different scenarios it could be.
Thank you so much, Dr. Cowhay Barnes, for sharing your time and your expertise with all of us today. And if you'd like to watch this session again at a later time, it will be available on the conference platform within the next hour. You can access this session and just click replay, or you can also find it navigating the on-demand tab in the platform hub. If you have any additional questions, you can send it to us at any time within 3 ways. Send an email to our help account, which is help@aamds.org. Call our helpline 800-747-2820, extension 2, or submit your question to our Facebook page. Please do take a few minutes to complete the surveys, the session survey. Your input is very important to us and does help us plan our future educational programming. Remember, there's still time for you to visit the exhibit booths. And if you're interested in the support groups, they'll start in approximately 15 to 20 minutes. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today, making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 38 years. This concludes our session.